Hi, welcome back. This is the Coding Coach. I'm here today, and just like every other day, to give you CPC exam tips, interviewing techniques, and all info related to medical billing and coding. So if you find this video helpful, don't forget to like, comment, and subscribe. Also, make sure you hit the notification bell, ding, to see our videos as they first become available. So today's video is about risk adjustment and HCC coding. I'm sure you've heard of it, even if you're not familiar with it totally. I'm sure you've heard of it because HCC coding is super popular. It also pays well. And I'll do another video as well about HCC coding and just a lot more details about it as well. So this video is mainly for someone who already does HCC coding. Of course, anyone can watch it. You can learn from it. This video also is for people who do HCC coding. They will probably get a better understanding of what they're doing now. And if you've never done it before, you can definitely get an understanding of what it is and how to do it. So like I said, this video is for everybody. So we'll go over CKD, and if you're in tune with your medical terminology and your terms, you know that it is chronic kidney disease. So we're going to mainly go over the gist of what is HCC coding, risk adjustment models, a little things from CMS, because that's who regulates this. So we'll get into like the basic foundation of things with CKD, diabetes, cardiology, and I'll go very, very, very in depth when it comes to diabetes. So I got a lot of notes here because I probably have about 50 slides. So I wrote a lot of notes here, so you might hear me flipping back and forth through the pages. This definitely is going to turn into a series because if I would have went all the way into more HCC coding details as far as oncology and all the other areas, then definitely this may have been a 2-hour video. And I don't want to bore you with, I'm sorry, I'm in a good mood. I told you guys on another video before, I'm like a soundtrack, like something always applies to a song. So I might just sing a song in the middle of a conversation. Okay, so let's get started. Okay, the road to risk adjustment 101. Are you ready to learn? Okay. So first we'll stop by and take a look at common risk adjustment terminology. So when you hear the word risk adjustment coding, you're also going to hear an interchangeable term, HCC coding. And HCC stands for hierarchical condition categories, which are chronic conditions used to create a risk adjustment methodology. Medicare Advantage, parts A, B, and C, the basis for how risk scores are determined. So RAF, which is RAF. So if you see RAF, you're going to just say RAF. So your RAF score. Your RAF is a risk adjustment factor, the factor that goes into it going into a category. So RX HCC. If you know your terms again, then you know RX means prescription. So of course, with most, if not all, chronic conditions, you're more than likely going to manage it with medications. So there are certain codes that do not have a medical risk adjustment score, but they have a prescription risk adjustment score. So the prescription HCC, just like I said here, some codes adjust risk due to prescription burden of disease. Okay. Okay, we'll go here. So Medicare risk adjustment. Here's a brief overview of why it's so important, especially for Medicare Advantage, which receive their payments from CMS based on risk adjustment, which is basically to ensure they're getting the payments for the illnesses of the patient they're caring for. Of course, it's driven by the patient's risk score, demographics, health status, and all that goes into the hierarchy condition categories or the HCC model. And then it calculates a risk adjusted score. And we'll later look at how that's calculated. So every patient has a risk score. It's based on their age, sex, dual eligibility for Medicaid and Medicare, or if they're disabled. Another part of their risk score is determined by their health status, heart failure, COPD, diabetes, etc. So here we'll talk about, and I know the slide is kind of super little. I couldn't get it any bigger on this slide. But what I will do is go like really into detail, and you know, then you'll be able to still understand even if you can't see the slide. So what I also do is recording is I'll try to make it bigger. Let's see. You can still see it a little bit better than it was, and you see it has ages over here. Looks like from 0 to 34, then 35 to 44, 45 to 54. So there are ages over here, and so, a lot of things dealing with demographic RAF for Medicare enrollees. So again, I'll go into it with the spill I have here. And slide 5, which is the demographic RAF for Medicare enrollees. And here you can see the demographics, or sorry, you can't see. The demographics RAF for Medicare enrollees. 65 to 69 female gets a 0.312 RAF score, whereas a male of the same age gets a 0.30. And it increases as you get older, of course, and as the health burden gets worse. Okay, so it looks like I gotta make it smaller, or the rest of them's gonna be big going through. Okay, we can make it big like that, you can see it. So risk adjustment, the risk score. The higher the risk scores represent members with greater than average burden of illness. So if they have a high risk score, that means they're really sick. They have a lot of chronic conditions. They probably visit the doctor regularly for like diabetes checkup, heart failure exams or checkups and things like that. So the lower the risk score, it represents a healthier population. But also it can falsely indicate a healthier population. And what I mean by falsely indicate, if it's inadequate or incomplete chart documentation, and we'll talk about that later as well, or if it's incomplete or inaccurate diagnosis coding, then that may make it appear that the patient is actually healthier than what they are, because you're not capturing all of their chronic conditions, or you're not capturing the codes that have them with a greater burden. So the laptop look like it's getting low. I don't want to hang up on us. Okay, there we go. So risk adjustment HCC model. Okay, so you can kind of see this. Let me see. Yep, let me go up a little bit. Okay, so this is how it all comes together. The HCC model, you got the disease hierarchy. The diagnoses are into these diseases group called condition categories. And then you'll see hierarchy logic, which we'll go over in a second. And then there are some disease interactions that give you additional risk scores for certain diseases if they're combined in the same patient and managed. All this information comes from like hospital visits, whether it's inpatient, outpatient, physician offices. Of course, we mentioned the demographic value as well. This model is a prospective one to give you like a better understanding of the flow. And each January, the members' risk score on their reset for a new year of diagnosis data. So basically, in a nutshell, to give you an overview before we go any farther. So CMS wants to know, is this patient getting better every year, or is this patient getting worse? And the reason they want to know that is because that's going to determine how much money they're going to spend for this patient. That's going to let the insurance company know, well, this patient is going to be super expensive. They always going to the doctor, inpatient, outpatient. They've had a lot of surgeries or this. So that'll let them know if you're going to the doctor constantly, they're capturing these codes. That'll let the insurance company or CMS know that this patient is getting worse every year. So maybe the doctor isn't managing this patient's illnesses. This patient may not be compliant with medications. Whatever the case is, at the end of the year, this patient's risk score is constantly going up. Because remember, I said it starts over each January. So at the end of the year, they'll look at it and like, wow, this patient risk score is constantly going up. So remember, the higher the risk score, the more the burden of illness. So then they can also, in the same breath, see if the risk score has gone down each year. And then if it's gone down, they'll be like, oh, okay. So Miss Davis or Miss Smith is doing well. She's doing better. They're managing her condition. She's compliant with her medication. Her risk scores are going down every year. So she's getting better. So this just giving you a better overview. Okay, so risk adjustment HCC. Basically, this all kind of funnels down, and I'll make it bigger because I'm sure I can make this bigger. You can read this. Yeah, here you can read it, and I'll slide it up over the bar. There it is. Okay. So basically, this all kind of funnels down. We now have about 70,000 ICD-10 codes, close to like 9,000 that map into these risk scores. They go into 25 condition categories, which are withered down into 79 HCCs, and we'll look at how that's actually set up. So HCC hierarchy conditions, there are like 33 hierarchy condition categories. And let's see, code to the highest specificity, of course. And we'll go more into diabetes. And like I said earlier, diabetes is kind of tricky. And there are also codes we talked about earlier, and I wanted to just reiterate that as well, so you can just have this kind of grained into your mind, that there are some codes that have a prescription RAF score, which risk adjusts, but they may not have a medical RAF score. So disease hierarchies. Let's see, I can make this a little bigger for you. Let's see, let's slide it over again. Okay. And another trick you guys can do also is you maybe can like pause it and hold it still, and maybe you can see the words better, kind of blow it up. You know how your phone will let you zoom in or magnify. So disease hierarchies. Some of these HCCs override others. You saw that list, what you didn't see, and I'll put the slide up shortly. Certain ones based on the lowest number, you know, they override, like I said. So 8 will be better than 9. 17 will be better than 18. Whichever one of the lowest in these categories that go together would actually be the risk score you get because of the overlap. So I'll give you an example. So diabetes, for example. Diabetes with acute complications like, let's see, diabetic ketoacidosis or hypoglycemic diabetes. This would be like a HCC 17. See it here? HCC 17. So like chronic complications like neuropathy, renal, of course, you know, renal is your kidneys, your eyes, they will go into HCC 18. And diabetes without complications, which is your, you know, your regular diabetes codes, 11.9, they will go into 19. So this is how, you know, like I was just saying about the lower it is, it's going to override. So if you have the diabetes without complications and it's a 19, and you have diabetes with acute complications, of course, when you have complications, there's a more burden of an illness. So with the more burden of an illness, then it will overlap because it'll have the higher risk score. So if you have something acute, and it goes into category HCC 17, you will also ignore all HCC 18 and 19 diagnoses for diabetes in that patient. And if you have a patient with diabetes, with just neuropathy, and let's say they have eye issues, kidney issues, all from diabetes, you'll only get credit for one of them, but you'll eliminate any diabetes you had in category 19, which is diabetes without complications, or the regular 1119. And if you're just learning risk adjustment, a lot of these codes you already use, and it's just that you're not familiar with risk adjustment, so you don't know which codes are adjusting to which categories and things like that. So, of course, you can't see this. And what you can also do is, if you would like a copy of this presentation, I'll drop the link down below so you can get a copy of this presentation in your email and things like that, and you can get it off Gumroad. I'll put it on Gumroad. That's a digital site I use for like my study guides and things like that. So I'll put the link below in the description box, and you can get a copy of this HCC, and maybe you can print it out. You can see it better or have it. Or better yet, you can just play this video while you're cooking and while you're doing something else, and then you can learn and just retain what you're listening to. So HCCs included in CMS risk adjustment model with brief description. So let's blow it up. Oh, okay, that's good right there. So you might not see all of it, but you can see some of it. And you see how it has these categories. See where what we talked about earlier, where the arrow is, where it said HCC 17, 18, and 19, the blue portion, where it says acute complications, chronic complications, and diabetes without complications. So for cancers, you see it's 8 through 12, and I'll just smallen it here. You see 8 is metastatic cancer and acute leukemia. HCC 9, it says lungs and severe cancer. 10, it says lymphoma and other cancers. 11, colorectal, bladder, and other cancers. And 12, breast, prostate, and other cancers and tumors. So for cancers 8 through 12, 8 would trump 9, which would trump 10, 10 would trump 11, and so forth, the lowest category. Same thing here, 17 will override 18, and 18 will override 19. So disease hierarchy for 2017 CMS model. And when I did this presentation, and basically things are still the same. I did this presentation maybe about a year and a half ago, maybe 2000, end of 18 or something like that. And so I was really going right off the 2017 information and things like this. So it's basically the same. That's why I still shared it with you guys, because it's really nothing new, things like that, nothing to add to the presentation that wasn't already, already in place or anything. So disease hierarchy for 2017 CMS HCC model. And see on the far left, and let me see if I can blow this up for you guys as well. All right. Okay, come on through. Okay, so on the far left category, you have your hierarchy condition category. In the middle is a disease group is listed in this column, see it here. And the far right, then drop the disease groups listed in this column, the number it trumps. Let me see, let me show you the title, and let me go up. This will help. Oh, nope, change the slide. So there it is, right here. See where it says the hierarchy condition categories. It says if the disease group is listed in this column, you see, metastatic cancers, we just talked about that. And this is the HCC condition category. Then the disease group listed in this column. There it is. All right, make it back small. So this shows what we just talked about. If you get a diagnosis, you know, in HCC 8 for metastatic cancer, no matter what the other type of cancer you have, you're going to get a category 8. If you have lung or other severe cancer, it trumps the colorectal, bladder, or other cancers that's in HCC 11. So it's like the same thing with diabetes, which is acute, trumps the chronic, and the chronic, excuse me, of course, trumps 19, which is diabetes without complication again. Okay. So examples of a hierarchy in RAF or risk adjustment factors, and I'll blow this up. I'm sure you'll be able to see this. Oh yes, definitely. So I'll slide it up. Okay, we can do that. Okay. So here's examples. The first column, as you see, is ICD-10 code. The second column is the year. The third column is the HCC category. Fourth column is the diagnosis, the description. The fifth column is whether it overrides or not. And the sixth column is the risk score. Close it a little bit. Okay, you see at the bottom where it says, where my cursor is, 2018 demographic risk factor, 2018 risk factor, and this is one patient's, this is the patient's information. Different, I mean, it's not one patient, different patient's information. Okay, let's see. Oh no, on this slide I did one patient. I'm sorry. This is one patient's information. I got another slide here too, I think. Let's see. So here it is, your demographic, your risk factor, and your total risk factor. And how HCC works, like of course I mentioned that it starts over every year. For example, I'm an HCC coder. So now I'm doing everything in 19. I'm not coding for 20. I'm coding everything in 19. And that's going to tally that patient's score up for the year of 2019 as they went into this year. So once this year is complete, then once we're going into 2021, that's when we're going to code for 2020. So it works like that. So you see where the bottom of the first of 2018 demographic risk score here of 0.379, and then you see the second one of 0.318, and then you see the total for the year risk factor of 0.697. So override means that there's a score that's higher in the same category. So the override means that they're not going to get credit for that score. All of these diagnosis problems of this chart is one patient. Just an example to show you how the RAF is calculated. We have 19, which is diabetes without complication, 17, diabetes with complications. And remember, the lowest number, 17, will override 19. So let me make it bigger again. So you see here where it says, where my cursor, E06341. So that's diabetes type 2 due to severe non-proliferative retinopathy with macular edema. So it has no eye distinction. It doesn't say left eye. It doesn't say right eye. So it doesn't have a RAF score. Remember in a few slides back, I said you have to be specific. You have to be specific to the highest specificity. That's going to be very important to risk adjustment coding. So this tells you that this person had type 2 diabetes due to severe non-proliferative retinopathy with macular edema, but it doesn't tell you which eye. So 19 gets immediately eliminated because you have a diagnosis with the with the HCC 17, which is a bigger burden of illness. 17 equals risk score of 0.318. See? 17, 0.318. And this one is no RAF. Doesn't even have a score at all. So in 19, their risk score is 0.104. So if you can't read the chart to the left in order, you know, I'll get the diagnosis code on each line first. And you can later kind of, like I said, look up the diagnosis code. That's why I'll go through it like this here. So pay close attention to the third one in the red. See here? You would think it's down to the highest specificity like I talked about, but it is not. It is not. You can only code what's documented. So you could even put right eye, left eye, or anything just so you can get a RAF score. Because if it's not documented, then you definitely cannot code it. Now, when you're using the 0.3, you know, like we have here, the E0, excuse me, 8, that says 6, I'm sorry, E08.341. When you're using a 0.3 diabetes code, you're always going to have your fourth digit. Be careful when coding retinopathy. It requires 4 digits unless you do the unspecified. And you know, there are almost always exceptions, which in this case, it's the 0.311 in which you did get a RAF. You see here, 0.311, and it doesn't have a fourth digit, but it still has a RAF score. And this is missing the fourth digit. No RAF. Now, it's thing specific still. Like I said, the exception, because it says type 2 diabetes with unspecified diabetic retinopathy with macular edema. But it didn't say which eye. It did not say which eye. Still. Okay. Slide this over for you. So more sophisticated diabetes codes. Let me make it big for you. Here we go. Oh yeah, you can see it. So let me slide it up for you. Oh yeah, this is perfect. So here's more sophisticated codes. And of course, this one patient again. We have E1152 with diabetic peripheral angiopathy with gangrene. You see, there is a RAF score, 1.461. Then we have E1151. This type 2 diabetes with diabetic peripheral angiopathy without gangrene. Also a RAF score. Then we have our E1159s, we have our E1140, E1141, E1142, 11.9. We have those codes here. And the reason why they're more sophisticated is because one code can RAF to 3 different HCC categories. As you can see here, this E11.52, 3 different HCC categories. HCC category 106, HCC category 108, and HCC category 18. See? Okay. So the first code is E1152, and it's in HCC category, like I said, 106, 108, and 18. Remember I showed you in the beginning how the 106 overrides the 108. So they're only going to get credit for the gangrene. Now the yellow line here, let's slide it up some more. There really isn't a code for diabetic neuropathy. It's the DM code, which are the 11.4s. So mono, excuse me, mono, which of course you know means one. Mononeuropathy gets no RAF, and hereditary idiopathic neuropathy gets no RAF at all either. So let me slide the chart up so you can see the bottom of the chart. Okay, so look at the bottom of the chart. I always add all diagnosis. No, not only diabetes, but other complications too. Like gangrene here is added, atherosclerosis of the aorta, and gangrene is I-96, and you will see that a lot, gangrene, especially when it comes to diabetes. That's why you have a lot of amputations and things like that. What's interesting is that if the neuropathy, if it's not due to diabetes, or if there's a secondary cause like inflammation, you can get an additional RAF score. So that's why it's always good to be very specific. Put it in every diagnosis to make it as specific as possible. So we're gonna have some more examples of sophisticated diabetes codes. So more sophisticated diabetes codes, and let me make it bigger for you. It's working out all right. Oh, let's cancel that. There we go. So you see the ones in the yellow, they're two digits, and they both have no RAF. You have to add the third digit to get the RAF score. 11.6.2, type 2 diabetes with foot ulcer. So it wraps into both HCC categories. And let me see, you see here 11.621, type diabetes with foot ulcer. So it wraps into two HCCs, as you can see, 161 and 18. And category 161 gives you a 0.535, and 18 gives you a 0.318. So the 161 will override HCC category 18. You remember we talked about only getting credit for one. So some codes were wrapped into 2 or 3 categories. So that wouldn't be unusual. So the patient RAF score. The average Medicare patient RAF is 1.0, and the national average is 1.0. Like $9,000 non-MA, but depends on the region. It can be like 7,000 for RAF score. It just depends. MS reimburses 100% higher for every 0.01 RAF increase, which means about $900 for every 0.01 RAF increase. So, you know how we talked about the bigger the burden of illness is, and a lot of physicians are now in a lot of qualifying programs. So it's kind of like a lot of money to get into these categories, especially HCC coding. The diagnosis coding drives the RAF score. The RAF score drives the reimbursement. And proper documentation keeps the reimbursement. Because you know they'll come back and take it back. If some of you guys are coders and billers as well, I myself, you know how frustrating it is to have a claim go out. You know, you think it's clean, and then it comes back denied. You got to figure out why it's denied. You got to appeal it. You got to send extra documentation. So it's very good to make sure you're doing everything to properly retain the reimbursement. So it's important to understand this because it's going to happen over just more and more as time go on, because as you can see now, it's becoming more and more popular. So adjustments to risk score. And I'll just go over a few numbers that I got from, just reading through CMS and things like that. So when we was talking about it, and I was just saying it's more important to understand because more and more things are adjusting and happening as time passes. And in the past, these risk scores were determined by the Risk Score Processing Center, which gathered all of this information from all of these payers and all over. So now they're moving toward taking the diagnosis straight from the fee-for-service encounter forms. In 2017, it was, okay, so I did make some adjustments. In 2017, it was like 25 to 75%. 2018, it was like 50-50. 2019, 75 to 25, and 2020, 100% encounter data implementation. So the normalization factors are applied to keep average risk score at 1.0. For 2018, it was just slightly over 1.0 at 1.01. Then there's an MA coding pattern adjustment applied to adjust for the difference in coding patterns. So MA plans or Medicare Advantage, MA plans depend on coding. They're more aggressive at coding than traditional Medicare patients because they're under different guidelines. And there's no one really overlooking their coding. So you'll see about 5.66% deficit for the risk scores, meaning they'll get about 94% of their risk scores compared to the non-MA plans or the traditional Medicare. So documentation is invalid without these 3 points. So diagnosis, you need to make sure with HCC that this is a face-to-face visit. 2, the status or condition. Make sure that your physician or the documentation says stable condition, worsening, labs or tests ordered, medications adjusted. Make sure the status is there. And 3, the plan of action. COPD, stable, continue current medications. So continue the current medications is the action or is the plan of action for this patient managing their COPD. So why documentation and specificity important? Okay, so let's see. You see B19.20, hepatitis C, unspecified, no RAF, no HCC. B1710, hepatitis C, acute, no RAF. But here, B18.2, hepatitis C, chronic, here it is, RAF score. So remember we talked about HCC is capturing chronic conditions. So the chronic implies this is ongoing surveillance, ongoing treatment, and now you have a RAF score. And documentation for every diagnosis must have the meat. So documentation and the meat. So meat, M-E-A-T, monitor, evaluate, assess, address, or treat. So the monitor, you're gonna monitor the signs and symptoms, the disease progression, is it getting worse, or the disease regression, if it's getting better, your condition is getting better. Evaluate, that's when the tests are ordered. Test results, medication effectiveness, response to whatever treatment. I'm evaluating, seeing what's going on. Assess and address, order and test, discussion, review records, and then I'm counseling. Of course, the physician, when I say I'm counseling. So treat, any medications, any therapies, any modalities, anything that you're treating or how you're treating it. So progress notes. You must evaluate each diagnosis on the progress note. Has to be face-to-face, cannot refer to problem list as documentation. 1, diabetes with neuropathy, stable, meds adjusted. Congestive heart failure, condensed, continue meds. COPD, PFT order. Refer to pulmonary. Hypertension, uncontrolled, add medication. Hyperlipidemia, stable on meds, check labs, and increase exercise. So the diagnosis listed on this progress note without an evaluation or assessment is considered a problem list and does not provide correct documentation. So if it didn't say stable, meds adjusted, or compensated, continue meds, or referred to pulmonology, or uncontrolled, it would just be a problem list. But once you add the documentation to it, it then becomes valid in a progress note and not just a list. So we're also going to do definitive coding only. Stop. In the name. Sorry. Okay, progress notes. Okay, we're here. So stop, definitive coding only. You do not, will not, cannot, please not code anything probable, suspected, possible, maybe. They're saying you don't know. They don't know. You don't know, you know. So you can't code anything that's not there. You can't take a wild guess or anything like that. You can't just, if they saying it's probably, then mean it could be probably not as well. So we're going to do definitive coding only. Do not code non-definitive conditions. Probably, probable, possible, questionable, rule out, no. Code the condition of the highest degree of specificity, signs and symptoms, abnormal test results, and other reasons for the visit. So you must have a clear relationship to the diagnosis. Acceptable linking with the verbiage. You know how you have hypertensive heart failure, and you link that together as far as if the patient has heart failure and they have hypertension, and knowing when to link it together into code. Or if they got CKD with diabetes and knowing when to link it. So you must have a clear relationship to the diagnosis and diagnosis. An acceptable linking verbiage is due to, because of, related to, thumbs up. You say, I can tell that's because of, that's related to, that's due to that. So not acceptable, the word with does not establish a cause and effect relationship, except in the case of diabetes. So pay close attention, best practices on specificity. And I'll make this bigger because this is super important. All right, and I'll slide it up. There we go. So the history of indicates a condition no longer exists to coders. History of, it's got history of cancer. You had a history of it, you no longer have it anymore. And of course, cancer can be eradicated. It can be eliminated. You can do chemotherapy, you can do radiation, you can do excisions or surgeries. So history of, remember, indicates a condition that no longer exists to coders. No longer exists to us. Pay close attention. You see the eyes. Pay close attention to list headers such as past medical history. Use caution when documenting the terms history of. Should not be used for chronic conditions receiving current treatment. Because if it's a current condition that's receiving current treatment, then you can't say it's a history of because it's still there. So instead include current status, dates, treatment, etc. So instead of documenting history of diabetes, patient with diabetes since 2019. And it's just the best practices when it comes to documentation. If you have to query your physician, or if they ask you for your advice, or what's better for you, or what's the guidelines as far as how am I supposed to do it. So these are a few examples of how you can, how it can be documented to the best practices specificity technique. So history of diabetes, just history, doesn't tell me when or what's going on. Patient with diabetes since 2019. This let me know that it's ongoing, and this patient has had it since 2009. I'm sorry. Patient has had diabetes, still has it, patient with since 2009. History of congestion, heart failure, meds, Lasix. Compensated congestive heart failure, stable on Lasix. It didn't say if it was stable or not here. Just said meds was Lasix, but you didn't say if it was stable or not. So history of COPD, meds, Advir. COPD controlled with Advir. See the difference? See the difference. Okay. So document. If it is not documented in the medical record, then it did not happen. You cannot make this up. Not this. Can't make it up. So these conditions do not reset each year. They are permanent. You remember I said every January that the conditions reset, and then we'll know from there if the patient is getting better, if the patient is getting worse, or how it goes. So These conditions do not reset each year. They're permanent. And you must include permanent conditions each year and, as you roll over. Transplant status, quadriplegia, dialysis status, any current ostomies, amputation, and asymptomatic HIV infection. So, prescription RAF scores, Medicare Part D for Medicare Advantages, and not MSSP. Let me see. Will it get bigger? Can you see it? Not really. So we talked about the medical RAF. There's also a prescription RAF for Medicare Part D and Medicare Advantage. So no medical RAF has a prescription RAF. So ICD-10 have 0 RAF for HCC. Here are the ICD-10 that have 0 RAF for HCC, but they do RAF for prescription HCC for meds on Part D. Let me move it for you. And let's see if I can remember some of these codes by heart. Let's see. Okay. So, let's see, hypothyroid, I think that's EO 3.9. You guys can kind of like check behind me and you can leave in the comments like, hey, Dakota Coach, you didn't know that one by heart. You needed your book or you needed your encoder. Okay, so hypothyroidism, I'm gonna say that's gonna be E as in Edward 03.9. So panic disorder, phobia, ADD. So panic disorder, I think this F41.8. Phobia, not sure. I think ADD is going to be F90.0 or either F90.9, but I'm leaning toward F90.0. So hypercholesterol is going to be E78.5, which is hyperlipidemia. But if it's going to be mixed hyperlipidemia, then it will be E78.2. And then if it's going to be cholesterolemia, it'll be E78.00. And they have to document it, but if it's just a hypercholesterol, you're just probably going to use the E78.5, which is unspecified hyperlipidemia. General anxiety, that's going to be F41.1. Dementia and Alzheimer. Dementia, I think is F03.90. And I think that's without behavior disturbance. Can't think of Alzheimer's at the time. Migraine. I think there's going to be G43909. Not sure what glaucoma is. Ischemic cardiomyopathy. I know it's going to be like in the eyes, maybe because that's, your heart thing. I think it may be I-35.1, either I-36.1 or something. So, carotid stenosis, not sure. Cerebral disease, cerebral vascular disease. I think it's going to be I-63.9, the TIA. I think it's I-63.9 for the cerebral vascular, and the TIA, not sure. Asthma, J45909. Oh, okay, we have more. We have GERD, that's K21.9, and osteoporosis is going to be M81.0, if I'm not mistaken. Not mistaken, yeah. Don't forget to check back behind me because the Code Coach does not know everything. Of course, I need my book sometimes. That's why they allow you to have your books for your exam because they know you're not going to remember all of this. Okay. So, RX HCC risk scores. So here is the risk scores for prescription for these different diseases. See? Chronic hepatitis, thyroid disorder, hypertension known as I-10. Major depression is going to be F32.9. Congestive heart failure is I-50.9. Diabetes without is going to be E11.9. COPD, J44.9. I think kidney transplant status may be Z as in 094.1. So I do remember some. So disease interactions. Oh, this is a good one. This is how they really get their money. Some diseases interact with each other, causing an increase in care management and corresponding additional risk factors. So let's take a look at this. Is that crazy? No, here it is. So again, some diseases interact with each other, causing an increase in care management and a corresponding additional risk factor. Basically, this is saying that some diseases interact with others, and it causes you to need more care. And as a result of you needing more care, then you have additional risk added. Let's see. Congestive heart failure, HCC 85, RAF 2.323. So on this side, diabetes with chronic complications, 18 category, 0.318. The RAF scores are totaled together, and it's going to equal 0.641. The disease interaction RAF, which is congestive heart failure and diabetes, it RAFs to this. And remember we talked about linking. So when you're linking, it's their interaction. One is because of the other. But you don't have to code this. This happens automatically behind the scenes, but it's most important to understand what these interactions are because you get additional RAF scores, as you can see. So it just adds up to more money for the patient. Nope. Okay, so let me go to the next slide. So congestive heart failure interactions, they have additional RAF score. You see how CHF and DM, which is diabetes, of course, is going to equal 0.154. Congestive heart failure and COPD. Congestive heart failure and specified heart arrhythmias. Congestive heart failure and renal disease or failure. COPD and cardiorespiratory failure. Cancer and disorder of immunity. So a lot of these interact with each other. And once you get the, learning more about HCC coding, or if you're already a HCC coder, or if you're doing, once you're being repetitive, it'll just come like second nature, like riding a bike or, cooking the kids some dinner or whatever the case is, it'll just come natural. So here's some DM ICD-10 codes. E08 point, diabetes due to underlying conditions. These are the categories for that. E09, drug or chemical induced diabetes. E10 is type 1. E11, of course, is type 2. E13 is secondary diabetes. And Z79.4, use of insulin, does RAF is HCC 19. So basically, if you have a patient who you're coding for, and if this patient is on insulin, you're going to always code the Z79.4, which is long-term use of insulin. The only time you don't code that on a patient's chart, if that patient has come in for a visit that day and get a prescription for insulin. And you won't code that because it then wouldn't be long-term use of insulin. They're just getting the prescription. So but any other time you're coding chart for diabetes and they're on insulin, that's why I was talking about medication earlier as support. Make sure you're going to put the Z79.4 because long-term use of insulin has to be there, needs to be there, it needs to be captured for a patient who has prescriptions for insulin. And this also lets you know that, there are exceptions, like I talked about. Now, most Z codes do not have a RAF score, but of course, there are exceptions. Like an ostomy, that's a Z code, and it has a RAF score. And of course, as you can see, this long-term use of insulin also has a RAF score as well. So quality documentation in diabetes, of course, I just said E10 is type 1 and E11 is type 2. And is there a manifestation or a complication? Many diabetes have some manifestation or complications associated with it. If it does have a manifestation, name the manifestation in the system and state manifestation due to diabetes. It should come in, the comment should be saying controlled or not controlled. So I can make this bigger for you as well. So the left column says diagnosis, the middle ICD-10, and the far right is the HCC weight or the RAF score. Every patient with diabetes should be evaluated for the many manifestations, comorbidities of the disease and complications, with the progress notes and tests showing this evaluation was done. So basically, in a medical chart, if you have diabetes, there are going to be other tests that you need to have done. If I'm remembering correctly, like an eye exam, diabetic eye exam, you have to have that screening once a year. So it has to be in your chart, whether you had that screening, is it coming up? Did you try to schedule it? So when you have diabetes, you have a lot of other diseases that can manifest. And so the doctor is responsible for, managing or evaluating and running tests and things to make sure that their patient doesn't have any manifestations of the disease. So the diabetes will of misfortune. Complication of diabetes are the most frequently omitted conditions in physical medical record. So almost every organ system in the body is impacted by diabetes. The kidneys, the eyes, the heart, the feet, like diabetic foot ulcers. The complications need to be documented. They need to be documented. They're important. So diabetes codes that do not RAF, diabetes with ophthalmologic complications, E08.3 or E11.3, except unspecified 311 or 319. Now, must have 4 digits because the 4 digits lets me know which eye. Which eye? Let me show you. So you see E11.321, it doesn't RAF. It does not RAF. Let me beat on the table because you got to understand this. You see E11.321, it does not RAF. And it does not RAF, listen to the description. Type 2 diabetes with mild, non-proliferative diabetic retinopathy with macular edema. Does not say which eye. Does not have a RAF score. It's not specific enough. We talked about that we talked about that earlier in the presentation as well. So now take a look. E11.3211. We got an extra number here. It does RAF. Type 2 diabetes with mild, proliferative diabetic retinopathy with macular edema is the same up here, but now right eye. And you see how the doctor can miss out on money? You see how the doctor can miss out on money? Just by one code being off, the doctor can miss out on some money. So that's why it's important to pay attention and know what RAFs and what doesn't. Now, this isn't anything that you'll have to probably remember by heart unless that's just your goal. There are many resources and tools and coding software, your book as well, that'll let you know if the score RAF. And if you do this a lot, if I were you, because this is what I've done in the past, I'll get a notebook and I'll write down all of my most common used codes. And when I see it, I'll put them in alphabetical order, or I'll put them in order by the group of the ICD-10. And when I see that code again doing the chart, I can just reference back to the little folder I created. So you see how it must have the right eye? The right eye. Now, diabetes with other complications like hyperglycemia, skin neuropathy, oral, using 2 digits. Must use 3, no RAF. Everyone thinks diabetes codes will automatically RAF. The exception is unspecified. That's the exception. That's the exception. But our diabetes code doesn't automatically RAF like people think they do. So that's why you have to pay attention, because they don't. Which you don't really want to use unspecified, because it'll RAF into multiple HCC categories. And as you might miss out on additional RAFs by not being specific. So you really don't want to use it, but if all else fails, then definitely you can use it. It just goes into so many categories. So proliferative versus non-proliferative. Unspecified retinopathy and with or without macular edema. Okay, so let me show you this. Okay, now you can use the unspecified. Let me show you why. Let me show you something. Let me enlarge it for you. Okay, here you go. Okay, so differentiate proliferative versus non-proliferative versus unspecified retinopathy and with or without macular edema. Let's take a look. 311, diabetes 2, unspecified diabetic retinopathy with macular edema. It does RAF. Didn't even have to put which eye. It does RAF. The unspecified does it, but think about it. If you get more specific, there's a higher RAF. So here again, 11319, same thing, unspecified diabetic neuropathy without macular edema. And it's the same RAF score, same category. So look at this, 11321, diabetes with mild non-proliferative diabetic neuropathy, retinopathy with macular edema, no RAF. Take a look. 11321, the extra digit 2, mild non-proliferative diabetic retinopathy with macular edema, left eye, it RAFs. It RAFs. Check this out. E11.351, diabetes with proliferative diabetic retinopathy with macular edema, no RAF. Must specify the eye. When I add the 1, the right eye, RAF scores. 11359, no RAF. 11351, RAF. Are you following me? Are you following me? Are you following me? So let's do a coding scenario. So type 2 diabetic is seen for a severe full thickness left heel pressure ulcer into muscle. The patient's history clarifies that the ulcer is secondary to diabetic peripheral neuropathy. The A1C is 9.6%. Physical shows very weak pedal pulses and purple cold toes with poor capillary refill. And you know, most people with diabetes do have circulation problems. They do. So, type 2, again, seen for full thickness, left heel pressure, ulcer, and 2 muscle. You see how the red is highlighted? See how the red highlighted? These are your diagnoses. These are your diagnoses. So how would you code this? How would you code it? You know? Do you know? Do you know? Okay. How would you code this? What would you document in the assessment? Diabetes with peripheral, with peripheral vascular disease, diabetic neuropathy, the diabetic induced pressure ulcer, and then the pressure ulcer stage 4. Oh, I didn't add all of it. Oh, this is another thing I wanted to add as well too. Oh, I lost my place. Here we go. Also, when you have pressure ulcers, or when you have ulcers and when you're coding in diabetic with ulcers, make sure you get the stage of the ulcer. Make sure make sure to grade and stage the pressure ulcer. There's a huge difference in the RAF scores when you do. So here's more examples with the diabetes. More examples. Okay. I think we talked about that enough. More examples. So need to be more specific. Let me see if I can move this. Okay. So 62-year-old obese, the BMI is 40. And of course, you know, if you're HCC coding, if you don't, if the BMI is 40 and over, you're gonna code the BMI because it RAFs. That BMI 40 and over has a RAF score. And then if you see obesity, you're gonna code that as well. That's E66.01. That has a RAF score as well. So 62-year-old obese with type 2 diabetes and diabetic retinopathy and age-related macular degeneration with congestive heart failure. Oh my God. My goodness, this patient has everything. So you see over here where it just said at the top with congestive heart failure. What kind? So you see here we got specific. We got systolic congestive heart failure. Still no RAF. So diabetes with chronic complications, type 2 proliferative diabetic retinopathy with macular edema, specific, but no RAF. RAF score 0. Notice these interaction RAF. CHF and diabetes, or RAF 0.154. So the total RAF is 0. But this is the correct RAF when you get specific. Let me show you. Okay, let me show you. See if I can make it bigger. Okay. So you see here we got E11351, which is diabetes with chronic complication, type 2 with proliferative diabetic retinopathy, macular edema. So let's get more specific. Exudative age-related macular degeneration, right eye. Systolic congestive heart failure, obesity. All of that has a 0 RAF scores. And let's take a look to the right. So we're gonna look at the difference between this one. Has no indication of which eye. I added the eye. Now we have a RAF score. Now we have RAF scores. Then I added the age-related macular degeneration with the eye. And also that they have the neovascularization going on. It RAFs. I tell your physician to be more specific, and it'll probably RAF. You know, documentation is good to know because physicians love when you point out where they're missing money. So chronic congestive heart failure systolic. Not just systolic, chronic. And it's gonna RAF. See, it's just I-50.2. But when I get to the chronic, I'm gonna add a 2. Now it RAF. And remember I said earlier, the BMI, if it's 40 and over, it's gonna RAF. See? Instead of just regular obesity, which does not RAF, we're gonna capture the BMI. Always look for your BMI. And we went from 0 and would have had no money to RAF score. Total RAF of 1.752. And this approximately $15,000. $15,000. Look, oh, I'm sorry. Go back. Okay, here it is. So basically $15,000 that could have been, why is it doing it? It wasn't doing it at first. Okay. Oh, I know why, because I got it so big. So yeah, that's approximately like $15,000 that this physician would have missed out on. So now let's talk about CKD. Let's talk about it. Can we talk for a minute? Okay. So there are different stages to CKD. Now, if the physician has not specified which stage, use unspecified. It still RAF. It still has a RAF score, but just not the highest RAF score you could have had. It's still RAF. So that code is going to be not E anything. N18.9 for the CKD unspecified. So here you have a stage 1, 2, 3, 4, 5. And when you get to the 6th stage, that's your end stage renal disease. So from stage 1 is, it's not moderate, it's not mild, it's not anything. You just got stage 1 CKD. Could be acute, it could be chronic. And it also goes by different measurements and proteins and a lot of things dealing with your blood or urine and things like that. So when you get to stage 2, you're going to have mild CKD. And these codes are easy to remember. And how I remember is N for nephrology. And nephrology means your kidney. So if it's stage 2 kidney disease, then you know it's nephrology 18.2. Stage 3, moderate. Nephrology 18.3. No, and stage 1 through 3 doesn't have RAF scores. Does not at all. So stage 4 is severe. Stage 5 is kidney failure. And stage 6 is end-stage renal disease. And definitely when you're on stage 6, you're definitely on dialysis. And it's 2 different types of dialysis. You have the peritoneal dialysis, and you have, and then you also have when people go to the dialysis centers, you get hooked up to dialysis and you sit there all day. And the peritoneal is done basically mainly at home. Okay. I think I might have skipped the slide. Open up. Okay. So this is secondary to diabetes. If you see it in a chart coded, this presents complications. Proteinuria is documented in a chart. It's secondary to diabetes. Make sure you still code that. Also has a lot to do with CKD. And now you can use the E11.22 code, which is diabetes with CKD, and that RAFs to score 18. Anytime you see microalbuminuria and proteinuria, then you're gonna say it's secondary to diabetes. So now let's talk about cardiology. That's the big thing in HCC too. So you're gonna be specific, avoid less specific terms. Coronary artery disease, that's specific. Atherosclerotic heart disease, and I know CAD is I-25.10. And then if you got angina, then I think specified is like I-25.119. And then without, I think maybe this I-25.111. So I remember those. If the patient has more specific diagnosis, angina, a lot of people pronounce it different, treated or untreated with pharmacological treatment or interventional cardiology. I need to know if it's treated, is it unstable? Are you taking medicine for it? What's going on? So now it remains active if the prescription is active. Now, angina or angina resolve with PTCA or, or stents or bypass grafts, and no further medication cannot be coded as active. So if they've got it resolved, then it's not active anymore, and you can't code it as being active. Now, beta blockers are prescribed, whether symptoms are present or not. So you will code it as active. We're almost coming to the end of the slide. So myocardial infarctions, there's just another term for heart attack. Just like if I wanted to say physician or doctor or attorney or lawyer or teacher or educator. So myocardial infarction is the same thing as a heart attack. Now, we just talked about only coding when the illnesses are present and active. As you should know by now, there are exceptions to the rule. So heart attack is such a traumatic experience that that's an exception to the rule. So if a patient has had an old heart attack, you're still going to capture that. I don't care how long the heart attack has been or whenever the case was, if their heart is doing good now. If it's documented that they've had a heart attack, then you need to document that old infarction. And I think that's going to be I-25.2 if I'm not mistaken. So let's see. Let me blow this up. Let's see what's written here. Okay. So acute MI, which is going to be I-22.9, only 4 weeks after the diagnosis is made. Now, if you have a face-to-face office visit within 4 weeks, then the correct code is going to be I-22.9. Now, if the patient is seen after 4 weeks of an acute MI, then, acute MI and has no continued ingenial symptoms, the correct code is going to be I-20, just said I-25.2. Recent MI, OMI, or history of MI. If angina or angina symptoms persist, code I-20.9. Acute becomes old after 4 weeks. Remember that, remember that, remember that. Acute becomes old after 4 weeks. So here we go. Let's take a look at some more cardiology codes. So like we mentioned earlier for CHF, you only get credit for one of the following. You see you have congestive heart failure, I-50.9, and here's the RAF. Then you have congestive heart failure again with these codes, no RAF. Acute on chronic systolic heart failure, I-50.23. RAF. Dystolic, RAF. Left heart failure, RAF. Pulmonary hypertension, RAF 4. So once an arrhythmia, always an arrhythmia unless permanently corrected. Without ongoing treatment as far as medicines or any kind of mechanical intervention like stents or grafts or pacemakers or things like this. So once you have an arrhythmia, you're pretty much always going to have an arrhythmia. So let me blow this up for you. And this is the last slide. Arrhythmia. So AFib, atrial fibrillation, and most you might see AFib. You see that a lot because I never really seen a physician spell out the whole thing. I usually just only see them put AFib. So you got I need this code for later. So you have your AFib, which has the weight. You have your atrial flutter, your sixth sinus syndrome, your AV block. When you see that atrial ventricular block, and you might see AV block, it's the same thing. So you got your PSVT. You have your paroxysmal ventricular tachycardia, and then you have your ventricular fibrillation. So an additional 0.105 RAF is given for congestive heart failure and arrhythmia interaction. So that's the last slide, you guys. I hope you really enjoyed this video. As you see, I've been very consistent for the last month. I promised you I was gonna rearrange my schedule, get more consistent, bring you more videos, be more helpful, give you all of the guidance that I wish I had when I was, when I was going through my coding school. It was a few videos in YouTube and things like that, but it wasn't like it is now. So again, thank you for joining me for all my exam tips, interview strategies, just all things related to coding and billing. If you find this video was helpful for you, please like, comment, subscribe, drop your comments down below, drop your questions down below. If there are specific things you're struggling with, if there's a video you would like for me to make, if there's something you want me to explain better, just drop the comments down below. Just holler at your girl, and then I'll be able to fix it for you. I'll be able to make the video for you, answer the question for you, and I will see you later. The Coding Coach is out.